There's no better feeling than a personal win, and the State Farm Personal Price Plan can help you do just that. Talk to a State Farm agent today to learn how you can bundle and save with the Personal Price Plan. Like a good neighbor, State Farm is there. Prices are based on rating plans that vary by state. Coverage options are selected by the customer. Availability, amount of discounts and savings, and eligibility vary by state.
Well, hello. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach nursing concepts and share tips to help you thrive in nursing school and at the bedside. Today, we are talking about hypertensive crisis. And as we talk about this condition, we will be touching on a little bit about the medications utilized. And that leads us into our listener shout out, which goes out to Alina, who is a student using fast pharmacology. And here's what she says. Fast pharmacology is an easy to follow, quick overview of medication that you can listen while driving. I love that it is not too broad, just the information you need for clinical or tests. Thank you so much, Alina, for sharing your feedback on fast pharmacology, and I love that you're using it exactly how I intended, as a quick overview that really just focuses in on the key things you need to know. It vastly simplifies pharmacology, and you can listen while you're doing other things like driving or walking your dog or loading the dishwasher. So thank you so much, Alina. Now, if you are interested in exploring fast pharmacology, then you can go to straightanursingstudent.com/fast to check that out. I'll also put a link in the episode notes. So today we're talking about hypertensive crisis, and a hypertensive crisis is a sudden and severe increase in blood pressure, where that systolic pressure is above 180 and or a diastolic pressure above 120 millimeters of mercury. So there are two types of hypertensive crisis. One is called hypertensive urgency. This is when the patient has that highly elevated blood pressure, but they're otherwise stable. They don't have any signs of organ damage. Now, this usually occurs in patients who have not been following maybe their sodium restrictions very closely, or maybe they're not taking their antihypertensive medications as prescribed. So that is hypertensive urgency. And then hypertensive emergency is when we have that elevation in blood pressure along with signs of end organ damage. So if you've not heard the term end organ before, you might be wondering, what is that? That is simply an organ that is showing signs of disease or damage as a result of some other thing going on with the patient. This is often the kidneys, the heart, the lungs, and the brain. For example, in cases of hypertension, just regular everyday hypertension, patients get end organ damage in that they get renal damage. So that's what we mean when we say an end organ. You may also hear this called a target organ. So you might be wondering now, what do I do when I take my patient's blood pressure and I get a reading that's above 180 systolic or above 120 diastolic, or even just any elevated blood pressure? I want you to reassess. We always want to double check our measurement. So let's ensure the cuff is an appropriate size. If that cuff is too small, what's going to happen to the blood pressure reading? It would be falsely elevated. Excellent. And if the cuff is too big, it's going to be falsely low. And I really hope that when you get a blood pressure reading of 185, you go and check the cuff. If you've got a too big cuff on, when you put that appropriate cuff on, it's likely to read even higher. Let's hope that doesn't happen. So let's check and make sure that the cuff is the appropriate size. We want to make sure it's applied correctly. You would be very surprised how often the area that is supposed to be over the brachial artery is twisted all around, or the cuff has fallen down and now it's kind of bent at the crook of the elbow. You just want to make sure that it's on correctly. And you also want to make sure the patient is still and quiet while the reading is occurring. The patient should be seated or in semi-Fowlers as, their condition allows. Maybe they have to be supine because of their condition, but semi-Fowlers is great, and their legs should not be crossed. You also want to check that the arm is supported at the level of the heart. So if the patient's in bed, you could put a pillow under their arm. If they're sitting in a chair, you can have a little table there for them to rest their arm on. And really important, if you can, to have the patient sit quietly for 5 minutes prior to the measurement. So there are actually quite a few things that can make a blood pressure falsely elevated. I mentioned if you've got too small of a cuff. What about sitting? Let's say you have your patient sitting in a chair, but they don't have their back supported. Let's say they are sitting in the chair, but they're sitting kind of close to the front of the chair, or maybe they're sitting on the edge of the bed, and now their back is not supported. This can increase blood pressure by 6 millimeters of mercury. And then crossed legs, which I mentioned earlier, can increase blood pressure by 5 to 8 millimeters of mercury. So let's say you've got a patient who's sitting on the edge of the bed and they've crossed their legs. Now their blood pressure could be falsely elevated by up to 14 points. What if that arm is dangling unsupported? That can add 10 to 12 points to your reading. So as you're envisioning this patient sitting on the edge of the bed, no back support, legs are crossed, and the arm is dangling unsupported, now we have a possible increase of 26 millimeters of mercury. Let's make this assessment even more abnormal. Let's have the patient talking during the assessment. That can increase systolic blood pressure by up to 10 millimeters of mercury. And here's something I learned that was very interesting that I had no idea about. If the patient is actively listening, this can have the same effect as the patient talking, causing an increase up to 10 points. So that means if you're taking the patient's blood pressure, you are not talking either. You're both being quiet. And here's a really big one. Have you ever seen patients at like a health fair where they're stopping by a booth to get their blood pressure checked? Well, if that measurement is taken on top of clothing, that can increase blood pressure by up to 50 points. 50. It varies widely, but it can increase it that much. And then, of course, using too small a cuff, which I already mentioned, can increase it by 2 to 10 millimeters of mercury. And the patient having a full bladder can increase it by up to 15 millimeters of mercury. So if you get an elevated blood pressure reading, I want you to really think through, have I done all the things to set this patient up for success so that we can get the most accurate and true blood pressure reading? So if you do all these things and your reading still comes back high, then we're looking at a patient with, potentially a hypertensive crisis, which again, 2 types: hypertensive urgency, which is without signs of organ damage, or hypertensive emergency, which is signs of organ damage. So now let's talk about that organ damage. The patient with a hypertensive emergency can have any organ affected. So their signs and symptoms can vary a lot. It's going to depend on which target organ or end organ is affected. So let's talk about neuro. If the brain is affected, the patient could have changes in level of consciousness. They could be confused. They could have neurological deficits, look very much like they're having a stroke. They could have blurred vision, nausea and vomiting, even seizures, and again, it could even lead to stroke. Usually what we see with a hypertensive type stroke is a bleed. So your patient with hypertensive crisis who has neuro changes is also going to be evaluated to see if they're having a stroke. Another organ that could be damaged is the eyes. It can cause retinopathy in your patient. And then the lungs. The patient could get shortness of breath due to pulmonary edema, which is actually related to cardiac because the organ, the heart, can get damaged, causing acute heart failure, which then leads to pulmonary edema. It can also cause myocardial ischemia and arrhythmias. The vascular system can also be affected. The patient could have an aortic dissection. And if your patient has a very, very high blood pressure and is complaining of severe chest and or back pain, those are signs of an aortic dissection. This is a massive medical emergency. And then the renal system can be affected. The patient could have acute renal failure. So what you'd probably just notice is decreased urine output, or, the urine that is present is very dark and concentrated. And then in pregnancy, hypertensive crisis can lead to eclampsia, which is that point where the patient is having seizure activity. Again, a very serious medical emergency for both the mother and the baby.
Hey, it's me, the Quenchies. I'm that late afternoon craving you just can't shake. Wait, what's that? Welch's Grape Aid? No! Made with real fruit and no added sugar, nothing answers the call of the Quenchies like Grape Aid. Got the Quenchies? Grab a Grape Aid in your juice aisle.
So now that you kind of understand what hypertensive crisis is and how serious it can be, let's talk about how it is treated. So one very key thing to know is that in most cases of hypertensive crisis, the blood pressure should not be dropped too quickly. Doing so can actually cause ischemic damage in vascular beds that have essentially become accustomed to that higher pressure. And we're really concerned about that in the brain. So in most cases of hypertensive emergency, that mean arterial pressure, or the MAP, is reduced by 10 to 20% in the first hour, and then an additional 5 to 15% over the next 23 hours. So what might this look like? So let's say your patient has a severe headache and blurred vision with the blood pressure of 187 over 112. So their MAP is 137. In that first hour, MAP should be reduced no lower than 109. We're going to reduce it by 10 to 20% in the first hour. So no lower than 109 for this patient. Over the next 23 hours, the MAP will be reduced to a range of 93 to 103. There are some exceptions, though. It's really important to know that patients who are experiencing some specific complications may need their blood pressure lowered more quickly. Patients experiencing an ischemic stroke, for example, who are candidates for reperfusion therapy, meaning they're going to get a thrombolytic. They do not usually have hypertension treated until the blood pressure is greater than 185 over 110. If the patient is not a candidate for reperfusion therapy, maybe they waited too long to seek medical attention and now we're outside the window for those therapies, the blood pressure is allowed to remain even higher, up to over 220 over 120 diastolic. And the reason we want to keep the blood pressure higher in these patients is to get as much blood flow to the brain as possible. Now, another exception is aortic dissection. This is, again, a very serious medical emergency. These patients will have blood pressure lowered more quickly to reduce further stress on that vessel and further aortic injury. Patients with intracerebral hemorrhage will also have more aggressive and rapid blood pressure control. So, just because in most cases the blood pressure is very carefully lowered, there could be some cases that you'll see where the physician will want it lowered more quickly. Now, what do we do, or what medications do we use to get the blood pressure back into that safe zone? So treatment for the patient is going to be tailored, of course, to each individual situation and can vary on that patient's specific complications. In general, common medications used in hypertensive emergency include vasodilators. These include nitroglycerin, nitroprusside, and hydralazine. These medications lower blood pressure by causing vasodilation. Note, however, that hydralazine causes something called reflex tachycardia, meaning when you give hydralazine, the blood pressure goes down, but the heart rate goes up. And this increased heart rate puts more work on the heart. So, for this reason, it is generally avoided in patients with acute heart failure and acute coronary syndrome and myocardial infarction. So again, that's hydralazine. The other vasodilators I mentioned are nitroglycerin and nitroprusside. Now, speaking of nitroglycerin, I do believe it is one of the coolest drugs ever. So if you want to take a little bit more of a dive into that medication, then go all the way back to episode 63. I was actually shocked to see that it was episode 63. It feels like I just recorded this episode within the past year or so. Clearly, I recorded it a while ago, but it goes into nitroglycerin, how it works, and all the different forms that it comes in. And one of those forms is an IV infusion. So that was vasodilators, very common medication used for hypertensive emergency. Then there are calcium channel blockers, and the key one here is nicardipine. And nicardipine is a specific type of calcium channel blocker that mainly exerts its action on blood vessels, causing them to vasodilate. And of course, vasodilation lowers blood pressure. And then beta blockers. Metoprolol and esmolol are commonly used. These medications decrease blood pressure by slowing the heart rate and decreasing contractile force. So 3 types of meds you'll often see for hypertensive emergency are vasodilators, calcium channel blockers, and beta blockers. And then once the blood pressure reaches and maintains safe levels with that IV medication, and that is a continuous IV infusion because we are titrating it, or in other words, lowering and raising it based off the patient's blood pressure to maintain that safe range. Once we reach a safe goal with IV infusion medication, the patient is transitioned then to oral medications. So let's now talk about what could cause a hypertensive crisis. And it can recur for many reasons beyond what I mentioned earlier, which was non-adherence to blood pressure medication regimen or non-adherence to sodium restrictions and kind of going overboard with that excessive sodium intake. So some other causes include renal failure. So the patient in renal failure, especially that patient who's in total renal failure on dialysis, this patient may become hypertensive due to a variety of factors, including fluid volume overload, which is a big one, increased vascular resistance, and activation of the RAS pathway. A lot of times for these patients, the remedy is dialysis. You give your patient their dialysis treatment and their blood pressure comes right down. We had a patient that would come into the ICU kind of, I wouldn't say regularly, but definitely more than once or twice, whose pre-dialysis blood pressures would be in the 220, 225 range and very, very scary, but did not have the signs of end organ damage. So they were more of a hypertensive urgency situation. And basically the treatment was get the dialysis nurse up here so this patient can get dialysis. Another is stimulants, both illicit stimulants and legal drugs that act as stimulants can precipitate a hypertensive crisis. These include methamphetamine and cocaine, the very obvious ones, but can also include glucocorticoids, NSAIDs, and nasal decongestants. Next is endocrine dysfunction. Both Cushing's syndrome and thyrotoxicosis or thyroid storm can lead to dangerously high blood pressure. Pheochromocytoma is another one. In this condition, a neuroendocrine tumor located on the adrenal glands causes the body to release too much norepinephrine and epinephrine, both of which increase blood pressure. And then heart failure. A patient with heart failure may become severely hypervolemic, which can increase blood pressure significantly. And then withdrawal. Patients going through alcohol or benzodiazepine withdrawal can experience dangerously high blood pressures. In addition, a patient who has abruptly and recently stopped the medication clonidine, which ironically is an antihypertensive, can experience hypertensive crisis. So there you have it, your quick overview of hypertensive crisis, which again is divided into hypertensive urgency, where the patient shows no signs of end organ damage, and hypertensive emergency, where they are showing signs of end organ damage. I hope this has helped you understand this condition more clearly. And again, if you want to dive into the medications I mentioned a bit deeper, I'd love for you to check out Fast Pharmacology. And did I mention that in this program, I teach pharm concepts in 5 minutes or less? That's what makes it fast. So go to straightanursingstudent.com/fast to check it out. And I would love to see you back here next week, same time, same place. Talk to you soon. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Did you know using your browser in incognito mode doesn't actually protect your privacy? Take back your privacy with IPVanish VPN. Just one tap and all your data, passwords, communications, browsing history, and more will be instantly protected. IPVanish makes you virtually invisible online. Use IPVanish on all your devices, anytime you go online at home and especially on public Wi-Fi. Get IPVanish now for 70% off a yearly plan with this exclusive offer at ipvanish.com/audio.